Welcome to the Physician Associate Podcast.
Hello, welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm joined by two PAs, Abby and Alys. Abby, do you want to introduce yourself first?
My name's Abigail.Mayo-Evans. I'm a Physician Associate on Cardiology.
Perfect. And Alys?
Hello, I'm Alys.montgomery. I'm a Physician Associate in Geriatric and Stroke Medicine, and I'm also one of the new Clinical Education Fellows.
Perfect. Thanks both of you for joining me on the podcast. The reason to get you on the podcast was to talk about this fantastic new teaching model that you guys have implemented around your trust. Who wants to explain the idea behind it and what it's all about?
So it's the Advanced Practice Academy is what we've named it. It's a 3-year rolling programme that's based on the Physician Associates core matrix. Each year kind of covers a core subject. So we had respiratory in the first year, cardiology in the second, and we've got gastroenterology in the third that we're just starting. And then we cover other specialities within that as well. So this year we're doing obstetric, general surgery, ophthalmology, some palliative care, and I always try and add in some practical parts to it as well. Possibly we're going to do some catheter insertion if COVID allows. We've already covered some practical sessions when we're able to. So yeah, and we also cover other things such as resilience. We've done quality improvement sessions as well to help people with any quality improvement projects that they're doing.
Thank you. Thanks. So for the uninitiated, who was being taught and who was doing the teaching?
So when it first started, Dr. Durand, who's the lead physician associate, she's a respiratory consultant at our trust. She wanted a teaching programme for physician associates that helped us pass our national exams every 6 years. It was a rolling programme every 3 years, so you had 2 chances to attend the sessions. We also, now it's grown and we've involved the advanced clinical practitioners within our trust. So it's aimed at our physician associate students and advanced clinical practitioners as well. The people who normally teach are our registrars, our consultants. We also have some CNSs that have done some of the teaching as well.
And that sounds brilliant as an idea to help improve your physician associates' clinical knowledge. How regularly are they being taught?
So the sessions are 1 hour a week, and it's protected time for the physician associates and ACPs.
What size cohort have you got of PAs and ACPs that are coming to this teaching? Is it well attended?
Yes, we've got within the trust we have 9 physician associates at the moment, and we're hopefully getting 2 or 3 more soon. There's 38 people in total. The rest are made up of our ACPs.
Brilliant. What an exciting opportunity to have that laid out for you within the trust. Alys, where do you come into this story?
So predominantly it was Abby that started the organisation of this project, this teaching session. Gradually I've found that I had a bit more of an interest in education, and I have recently gotten a job as a clinical education fellow working with the medical and PA students, and that's allowed me to work alongside Abby as well. We've been working together to organise speakers to come in once a week, and organising the feedback forms. Yeah, so it's very collaborative. Like I'm working alongside Abby with this.
Sounds great. I wish every PA was able to have that opportunity and for sort of a bespoke curriculum designed teaching in the trusts. What are the main benefits that you're realising putting this effort in?
I mean, teaching is a very important part of our growth and our development. We have, as PAs, we have to have our continuing professional development. We have points and hours that we need to make up to improve our clinical knowledge, our clinical skills. And this is a route for us, for everyone involved, to be able to access that additional training, that additional teaching, and continuing the professional development. And ultimately, it's just helping us deliver patient care by improving our knowledge and skills.
I would just add on to that as well, because it's protected time specifically for physician associates. It means that it's easier to actually attend the sessions. Previously, we attended the F1, F2 teaching, which is their protected time. So often I would find if it was just myself and an FY1 or an FY2, I would say to them, you go, it's your teaching, I'll stay, which meant I was missing out on learning opportunities. So I think it's really good that we have our own set protected time. We do also record the sessions as well now, so people can go back and use them as revision, or if they've missed the session for one reason or another, they can go back and then they don't actually have to miss any of the teaching at all.
Was it a hard sell to the powers that be to release you to go off to do that teaching time? Sometimes
it can be quite challenging depending on how busy the ward is, what the staffing's like. In theory, this is the time that we should be allocated to our teaching, and we should be able to remove ourselves from our clinical environment to attend. But obviously, if an emergency pops up, then sometimes that can be quite challenging. But the response that we've had from our clinical supervisors has been very positive, and they do try and facilitate everyone being able to leave the ward or A&E or wherever they are to be able to attend this teaching.
We've also had a lot of support from the managers and things like that. Our nephrologists are not actually they come from Birmingham and they do clinics in Hereford. The managers allowed them to shorten some of their clinics so that they were able to come and teach us for an hour. So they're very supportive as well.
Oh, amazing. One of the big advantages I can see as an outsider for you guys is bringing together a community of PAs, like a community of practice, just to support each other for other things apart from the clinical work. It's just nice to know that there are other people who understand what a PA is and have the same frustrations or the same problems sometimes, and you can bounce ideas around together as a group of PAs. It's nice to build that community, isn't it?
Yeah, we often have case-based discussions for certain specialties, and it's interesting because everyone, as a physician associate, everyone has such different professional backgrounds, so it always makes for interesting discussions because everyone has something, a different point of view.
It's lovely in this trust that we do have such a large group of PAs and advanced clinical practitioners, and as Abby said, everyone has a different backgrounds, whether professionally or personally, and being able to share that knowledge or just being able to share stories with them is really wonderful to gain different perspectives on aspects of medicine, and as well just having a support if there's been difficult cases or complicated cases to be able to talk it through with someone else who knows what we're going through or what challenges we're facing as well, particularly if we've come across a situation where another professional may not understand completely the PA role and face blocks or challenges around that. Being able to share that with other similar people is really lovely. It's really, really lovely to have.
If someone's listening to this, another PA in another hospital in another part of the UK, and thinking, this sounds great, this is exactly what me and my colleagues need where I am, what have you learnt? What would you do differently? What would you advise them on?
Just tell them to start by getting sort of their lead consultant involved to gain the support from managers and other specialties, and then to come up with a curriculum they want to implement, and then just start emailing the specialities. I send an email out to every single consultant registrar in that speciality. Some people respond, some people don't. It's just some people like teaching, some people don't, and go from there.
We have offered the incentive as well of once the session has been completed that we provide the speaker with a certificate of attendance and feedback from the students so that they can then utilise that for their own continuing professional development and as evidence of their teaching.
And are you finding that people are genuinely quite willing to come forwards, or is it difficult to find speakers because of the clinical pressures?
It can be. As I said, that some people like teaching and other people don't. I've had both ends of the spectrum. I've had consultants actually coming to me and saying, have you thought about having this as a session? We're really interested in helping and doing some of the teaching. And then other consultants that I've emailed and have no response from. So I think you just have to be able to adapt what you come up with. So for some of the specialities that aren't as keen on teaching, say I had 3 sessions planned for them, I would try and then narrow that down maybe into 1 session. So they only had to give up 1 hour of their time if they weren't able to do sort of the 3 set sessions. So I'd say it's just being flexible with the curriculum and what you're teaching.
What style of teaching do you find works best? Is it online virtual teaching that people can stop and pause and rewind? Do you find case-based discussions face-to-face? Is there something that's really effective or something that perhaps you don't think has worked that well?
We found that a variety of different teaching options keeps everything very fresh and interesting for everyone who's attending the teaching. So we have a variety of lectures. We have we have consultants that like to just stand up and talk or demonstrate by writing on a clipboard. We have some practical sessions where as Abby mentioned earlier, like for catheterization, or we've had speculum examinations, and then we have case-based discussions. So a variety of teaching methods we have implemented, and that does we have had positive feedback from that. But the lectures tend to be the most common, purely because it's the easiest thing to be able to record people to then go back and look at, and as you say, pause and rewind.
I think as well, particularly over COVID, it was difficult to, we couldn't have the practical sessions. Case-based discussions don't tend to work as well when everybody's online. I find that's better if people are all in a room together. So we have had some limitations with COVID, but Alys said, I think the variety of different styles is really good, because then there's something for everyone, really.
And the integration between PAs and ACPs, is that helping because you're seeing each other regularly and learning the same content? Is it relevant to all, or are there any difficulties in crossing professional boundaries like that?
No, I think it's really good to have the collaboration, and ACPs tend to come from a lot of different professional backgrounds as well. So I find it just adds to the discussions that we have, the questions that are asked, the content. So ACPs also have to have continued professional development, so that helps with their learning as well. And we get a lot of positive feedback from them, positive feedback from the physician associates. And ACPs are similar to us in the way that they're not doctors. They have some of the similar challenges as us. So I think it's quite nice to bring those two professions together to learn.
Brilliant. Thanks, Abby. And what about physician associates who want to be educators and teachers themselves?
So the brilliant thing about being a PA is that we have the opportunity to explore different aspects of medicine, and one of those is education. And we're quite lucky where we are in our trust that they have offered up an opportunity for myself to be able to be involved more with education. Quite quickly, we managed to get a post involved with it as a non-medical clinical education fellow, which I've gone for now. That's a role that I'm creating and working alongside the other clinical fellows to see how we can expand this role and how I can bring my background and my skills into this job, so that I can teach both PA students and medical students, and that alongside that, very keen on supporting me with doing like a postgraduate certification for medical education, and that can eventually be worked up to a master's in medical education as well. And we have a great deal of support from our local university as well, with opportunities to assist with like OSCE practices or being examiners for their for the university exams. And that's something that I had independently gone and researched and contacted the leads at the university and the clinical leads at this trust as well. And the response is very, very positive so far, and I'm very excited in how this role is going to develop. And I would really encourage, if any other PAs have an interest in teaching, that they contact their education leads and see if there's an opportunity for them to be involved with either leading lectures or doing on the ward clinical teaching. So that's where I started, was having students on placement, medical students, PA students, nursing students, and just starting to have those kind of conversations like on the ward clinically. And gradually now that's developed into a more formal position, a more formal role with more formal teaching that then involves ensuring that the core clinical matrix is covered and being able to provide that in a variety of different situations, whether that's lectures, on the ward clinical teaching, case-based discussions, small group workshops, and we do have a simulation suite as well.
Brilliant, thank you.
Also within our trust, a lot of the PAs do procedures like chest drains, midlines. I think Alys has learned how to do lumbar punctures.
Yeah.
So I would love to do perhaps a short course or something that was extra added onto the Advanced Practice Academy that had those procedures in it and helped our physician associates and ACPs develop those skills.
And then it becomes self-perpetuating, doesn't it? Because once you've got PAs that can do those skills and are competent and experienced in doing them, they can train the next generation of docs and ACPs and PAs that come. Brill, Alys, Abby, thank you so much both for joining me on the podcast today. It's been really useful to find out what you're doing in your hospital, and I hope it's something that will be a model for other physician associates in other trusts to recreate and learn from. If people have heard this episode, it may have sparked off questions about what they can do themselves, and they may want to find out more. Where would you point them to get more information about what you're doing?
So I'm happy for people to contact myself. Our physician associate lead, Dr. Durand, is also happy for people to contact her. So I can give you the details at our email addresses, if that's helpful for people.
Perfect, thank you. I'll leave the contact details you mentioned in the show notes so that people can find them there on this episode. Thank you so much for joining me. And thank you for listening as well. I hope that was an interesting episode for you to find out more about physician associates in secondary care and the teaching packages that are being developed to help support us through our revalidation and to improve our clinical learning with our ACP colleagues and others. If you've got an interesting idea for an episode of the Physician Associate podcast, please get in touch with me. I'd love to hear about you and get you on the show to find out more about what's going on with physician associates up and down the country. We're on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.